Assalamualaikum warahmatullahi wabarakatuh. Saya Muhammad Iman dari Nasri. Matrix number DID 11220105.
Hai, salam sejahtera. Nama aku Rahmat Agahana Riko. Nombor matrix DIT 11220179.
Assalamualaikum, saya Alia Maisara binti Jari, nombor matrix DIT 1122011181. Assalamualaikum, nama saya Noaina Fatihah binti Muhammad Nasri, nombor matrix DIT 1122011016. Concept of disease occurrence. A critical premise of epidemiology is that disease and other health events do not occur randomly in a population, but one more likely to occur in some members of the population than others because of risk factors that may not be distributed randomly in the population. As noted earlier, one important use of epidemiology is to identify the factors that place some members at greater risk than others. Agent, originally referred to an infection or pathogen, a virus, bacterium, parasite, or other microbe. Host refers to the human who can get the disease. Environment refer to intrinsic factors that affect the agent, and the opportunity for exposure environment factors include physical factors such as injury.
Descriptive epidemiology. Broadly speaking, epidemiological work can be divided into two main categories. Descriptive epidemiology, which includes activities related to characterizing the distribution of disease within a population, and analytic epidemiology, which concerns activities related to identifying possible causes for the occurrence of disease. Both types of epidemiology are fundamental to the prevention and control of disease and to the advancement of medical knowledge. Descriptive patterns of disease occurrence often lead to hypotheses about disease causation that are tested in analytic investigation. Analytic studies may yield findings that help to explain descriptive patterns and to improve surveillance efforts. Measures of disease occurrence. The tools for descriptive epidemiology are used to characterize the population distribution of disease. Toward that end, three basic questions can be asked. Who develops the disease? Where does disease occur? And when does disease occur? Collectively, these three questions serve as the basis for a descriptive investigation of disease. Answers to these questions characterize the distribution of disease by person, place, and time. As shown systematically in the figure given, these features are the standard dimensions used to track the occurrence of disease. A basic tenet of epidemiology is that diseases do not occur at random. In other words, not all persons within a population are equally likely to develop a particular condition. Variation of occurrence in relation to personal characteristics may reflect differences in level of exposure to causal factors, susceptibility to the effects of causal factors, or both exposure and susceptibility. Typically, the minimal set of personal characteristics examined with respect to disease occurrence includes age, race, and gender. Because such information is routinely collected on the affected persons or cases, as well as the unaffected population from which the cases develop, epidemiologists rely on these characteristics to a great extent. The use of other attributes of interest, such as level of education and income, marital status, and occupation, is contingent on the availability of data. It should be emphasized that these data are derived from information reported by physicians, laboratories, and other healthcare providers. The Centers for Disease Control and Prevention CDC define a notifiable disease as follows: a disease for which regular, frequent, and timely information on individual cases is considered necessary for the prevention and control of the disease. The compulsory collection of information on selected infectious diseases was authorized at the national level in the late 1800s. The list of nationally notifiable diseases is revised periodically in response to the emergence of pathogens that pose a threat to the health of the public. Reporting of notifiable diseases typically begins with a clinician forwarding basic information on a newly diagnosed patient to the designated local or staff health department. On a weekly basis, state and territorial officials transmit information about individual or aggregated cases of nationally notifiable diseases to the CDC. These reports follow a standard format, including information on the age, sex, and race of the patient, and data of occurrence of reported cases. Although reporting of notifiable disease is mandatory and sanctions can be enforced for non-compliance, these sanctions are rarely applied. As a consequence, reporting is often incomplete, with wide-ranging estimates of completeness for various notifiable diseases. A number of factors probably affect the likelihood that a notifiable disease will be reported, such as the clinical severity of the condition, whether the affected individual consults a physician, the type of physician consulted, for example, private versus public provider, generalist versus specialist, any social stigma associated with the condition, level of interest in the condition among clinicians, the physician's knowledge of reporting requirements, existence of an adequate definition of the condition for surveillance purposes, availability and utilization of appropriate diagnostic laboratories, availability of effective disease control measures, and interests and priorities of local and staff health officials. For a severe disease, in which clinical manifestation can be serious, clear diagnostic criteria and effective treatments are available, and the risk of interpersonal transmission is high. Complete reporting of diagnosed cases obviously is crucial. On the other hand, interpretation of reported numbers of cases must include the possibility of incomplete notification. A number of factors contribute to the non-random relationship between incidence of disease and age. 1. The long latent period between infection and development of clinical symptoms means that the age at detection of illness are expected to be skewed toward later life. 2. Because elderly individuals lived through time periods when the disease was more common, they are more likely to have been infected than younger persons, also known as birth cohort effect. 3. Older persons are more likely to have other illnesses, for example, cancer, diabetes mellitus, that may make them more susceptible to disease. 4. The decline in immune function associated with the normal aging process may increase susceptibility. And lastly, elderly persons are more likely to live in close communal settings that are conducive to the spread of disease. An equally striking non-random pattern of occurrence is seen when incidence is examined as a function of race or ethnicity. As exemplified by the subject of the patient profile, many of these patients acquire the infection in the high-risk country of origin, but do not develop symptomatic disease until they arrive in other countries. The high incidence rates of disease within certain minority groups in a country reflect the influences of other risk factors. The combination of crowded housing, poor nutrition, inadequate access to preventive and therapeutic medical services, alcoholism, and injecting drug use, as well as predisposing medical conditions, contributes to the high risk of disease among the poor. The distribution of disease by gender probably is related to difference in certain high-risk behaviors. For example, heavy alcohol consumption, as well as predisposing disease, AIDS and silicosis between males and females.
This can be evaluated at national, regional, and local level. Non-industrial countries have high rates of the disease. Underlying demographic characteristics of the various populations, including factors such as racial or ethnic composition and representation of immigrants from developing countries. Other risk factors: poverty, malnutrition, crowded living conditions, substance abuse, and infection with the disease probably influences the pattern of disease occurrence for example, San Francisco and New York. Time: it's began from 1980s, followed by the subsequent fall in occurrence is a remarkable public health story. A number of factors probably contribute to the rise of this disease, including among others. First, the emergence of highly susceptible population of persons infected with disease. Second, lapses in infection control practices in institutional setting. Third, the emergence of strain of disease resistant to multiple antibiotics. Fourth, failure of disease control program to ensure that person with active disease complete an adequate course of antibiotic therapy. Federal government appropriated substantial increases in fund to fight this disease. Additional resources, public health agencies were able to expand programs for disease control. The essential component of this control effort include: first, prompt identification of person with active disease. Second, initiation of appropriate treatment for person with active disease. Third, assurance that therapy is completed for person with active disease. Fourth, tracing of the contact of person with active disease. Fifth, testing for infection among contacts. And lastly, completion of preventive therapy in eligible.
Correlation with disease occurrences. To develop hypotheses about possible causes of disease occurrence, the presence of a sex risk factor can be measured in different populations and compared with the incidence of a particular disease. Ecologic study. For comparison, the analysis is at the level of an entire population rather than at the level of individual person. Correlation study. For investigation, it is to determine the extent to which two characteristics, risk factor and disease occurrence, are related. Studies, they are designed to test the likelihood of a cause and effect relationship between risk factor and a disease are termed hypothesis testing investigation. The two approaches most commonly employed to test association between risk factor and disease: alcohol and case control study. Related variables such as injecting the drug use can be considered in the design and analysis of the studies. Ecologic fallacy. An important limitation on the epidemiologist's ability to infer a causal explanation from a correlation study may occur when a suspected risk factor and disease occurrence are associated the population level but not at the individual subject level. In other words, population may have high incidence risk without the same person being affected by both conditions. Can be avoided only by making observation of risk factor and disease status on individual subjects. Method of analytic epidemiology, such as cohort and case control studies, involves observation on individuals and thus are not subject to the hazard of ecologic reasoning.
migration in disease occurrence. Another useful technique in descriptive epidemiology is the examination of the effect of migration on the rate of disease occurrence. Study of this type can help to gravity variable to disease of unknown cause is determined principally by genetic from high population to low risk population should not affect the occurrence of a genetically determined disease among the migrants. In contrast, migration from a high risk population to a low risk population is expected to be associated with a reduction in occurrence of an environmentally determined disease. Versus in the another way, migration diminishes the likelihood of exposure to environmental risk factor, and accordingly the occurrence of disease should decrease. Of course, for disease with long latent periods, it may take many years for the reduced rate of occurrence to become manifest. If environmental exposure early in life are critical, then the rate of occurrence may not be reduced among the migrants themselves, who were exposed prior to their invasion, but should be diminished among their offspring born in the new location. A dramatic change in disease incidence within a single generation could not be explained on the basic genetic change. Approaches to the study disease that are thought to have genetic predisposition are presented. A number of studies have indicated that a progressive decline over time among persons who migrate from high-risk area, example Asia, to low-risk area, example United States and Western Europe. The basic pattern of change in incidence is shown. The incidence is highest at the time migration and fall rapidly in the next few years. The decline continues for many years with smaller increment of change. Over time, the incidence among migrants does not fall to the level of general population. However, especially because of the latent patient acquire prior to migration, a factor that may contribute to the presence of an elevated incidence among migrants include the following. First, residents in migrant communities, thus maintaining a comparatively high rate of disease transmission. 2. Crowded housing condition. 3. Poor nutritional status. 4. Inadequate access to preventive or therapeutic medical service. 5. Non-compliance with therapy. 6. Presence of disease that is resistant to conventional antibiotic. 7. Infection on vitamin C to the country of origin. The overall decline in incidence of tuberculosis among migrants from high to low risk countries, however, provides strong circumstantial evidence about the importance of environmental determinant of this disease.